Thank you, Dr. Ashay, Vijay sir, for the opportunity. So to reconfirm my topic with the organizers, because this was a niche topic, I was like, why we obviously know that IOs don't work in driver mutated NSCLC. But you see, Pembro, I consider is at the Virat Kohli of NSCLC. Do I have anything else? Is Virat going to do anything else? So role of immune checkpoint inhibitors in driver mutated NSCLC is controversial. The early trials showed lack of benefit of ICI in EGFR ALK mutated NSCLC, and the data comes from subgroup analysis, retrospective data. So a poorly immunogenic NSCLC subtype, that is a driver oncogenic driver mutant. Role of TMB is controversial there, most are non-smokers. Role of PDL1, as Dr. Ashay has said, might not be the marker that we're looking for, especially in oncogene driven mutations. And the role of tumor infiltrating lymphocytes. Oncogene activation downregulates MHC1, impairing CD8 cells, so there is definitely less of tumor infiltration. What do we know till now? 2019 immunotarget registry, major mutations, RAF, RAS, MET, maximum was for RAS, ALK surprisingly showed zero response in immune checkpoint inhibitors, a poor PFS of 2.8. So this is just a gist, this is in the ASCO educational book. RAS stands out, the maximum response is 57%. So what exactly, what's the updates for EGFR? So I'll be discussing the use of IO in EGFR under 4 topics: monotherapy, post-TKI, variability in EGFR mutations, and combination therapy. So monotherapy. Do EGFR mutated lung cancers have less of PDL1? Because all our approvals for immunotherapy comes in PDL1 mutated patients. So it has been seen surprisingly that PDL1 expression is more. In vitro studies have shown that the treatment with PDL1 axis inhibitors in EGFR mutated is effective. And some reports in human tumors demonstrated a strong PDL1 expression in EGFR mutated disease, some not. So on the basis of this, expected that immune checkpoint inhibitors will be effective in EGFR. But, and this is just the cap of the previous slide. Looking at the first trial, that is the Keynote 001, PDL1 positive patient, that is the percentage score patients, 30%. Then we have the Atlantic trial that has used durvalumab in third line. So even in that study, PDL1 positive patients were in the range of 70. Then you have the Gainor that has used retrospective immune checkpoint inhibitors in treated patients. So there is decent expression of PDL1 in EGFR mutated patients. But in oncogene driven mutations, there are a lot of gene alterations. There is exogenous cytokines, the PDL1 amplification due to different pathways, or disruption of the 3' untranslated region of the PDL1 that might not make PDL1 the best target for immune checkpoint. This is visible in the overall response rates. So in the Keynote 001, EGFR mutant, EGFR wild type, we have a variable difference of around 20% in the response rates. This is in TPS more than 50. This translates into the overall survival. EGFR wild type TPS more than 50 is 15.7, while mutant is 6.5. This is the phase 4 trial of pembrolizumab in EGFR mutant patients. You see the overall response rate of 0%. So looking at these data, the further Keynote trials, the further immune checkpoint inhibitor trials have excluded EGFR and ALK mutant from their inclusion criteria. So there is currently no evidence to support IO therapy in first line TKI naive EGFR mutant. So definitely monotherapy, immune checkpoint, EGFR mutant, first line it is failing. Is there something else? Can I use it in EGFR post TKI? Why this premise? Because when there is a progression of an EGFR mutant or an ALK mutant on a TKI, there is an adaptive PDL1 upregulation. More of PDL1 upregulation, maybe immune checkpoint inhibitors will be effective in this subgroup. So this is what happens. This is the increased PDL1 expression. The repeat biopsies, PDL1 expression is higher. Does this higher PDL1 expression translate into a good response? So we have the classical study, that is the ABCP Empower 150. This study had a subset of patients who were EGFR mutant, ALK mutant. So you see in the in the curve, there is ABCP does do better in EGFR mutated and ALK mutated patients. So have we found out our second line agent in non-T790M mutated patients who progress on EGFR TKI. Can we use IO for all? So we have a few studies to address this. The Empower 150 and the Empower 130. So 130 use atezolizumab while Empower 150 use atezobev. Empower 130 could not achieve the response that was expected from it. So maybe atezo itself is not a great drug. Combination with bevacizumab is what might have driven the response. This is an old study from 2015, use of nivo and dosi in the second line. Going back, we don't learn from our mistakes. So even in this, immune checkpoint inhibitors might not be the best medicine for an EGFR mutated patients. So we had two large trials, Checkmate 722 and the Keynote 789. Both were recent trials, both have used nivo, Checkmate has used nivo and the Keynote 789 has used pemro. Both have been used in the second line post EGFR progression on first line TKI. Both studies are negative, they fail to meet the primary endpoint. So monotherapy is failed, second line has failed. Can I combine IO with an EGFR TKI? Multiple studies, very good response rates. But then we come back to one thing, that is the adverse effects. Poor tolerance, a lot of patients with grade 3 toxicity. So when I come to an IO plus EGFR TKI, combination might not be the best way forward. Maybe an IO plus a VEGF inhibitor, there is upregulation of PDL1. Not sure, there is no specific trial that has compared an IO plus VEGF with an IO alone. Next, can I use an IO in a different EGFR? The question comes because different EGFR mutations, that is the exon 19 and the L858R, have different TMB levels. Exon 19 mutants have a lower TMB mutation burden as compared to the EGFR L858R. But coming back to the same chart, I am 150. The second chart is for the sensitizing EGFR mutations. Atezo-bev does good, atezo alone is not doing great. So in summary, IO in EGFR mutant, targeted therapy, yes, definitely. Immune checkpoint inhibitors, maybe no efficacy, more toxicity. Target therapies plus immune checkpoint inhibitors, efficacy is not known, increased toxicity. And immune checkpoint plus chemotherapies, we are not even aware of the efficacy or the toxicity. Then in others, ALK, ROS, RET, mutated NSCLC, coming back to the immunotarget registry, all have fared poorly except KRAS. So is KRAS the only oncogene-driven mutation that is IO sensitive? Maybe yes. We do have one target for it, that is the KRAS G12C. Sotorasib, it is the first line. Is it the first line for this? So I think KRAS is the only oncogene-driven mutation wherein immune checkpoint inhibitors are preferred over to the targeted agent. So this is a brief outline of the drugs that we are using in KRAS. Even in the first line, we are still preferring an immune checkpoint inhibitors plus a platinum doublet. The targeted agents is in the second line therapy. So take home message, single agents are largely ineffective in oncogene drivens till date. This is the latest update from the Keynote 789. This was presented in ASCO this year. Chemotherapies, immune checkpoints are clearly not very effective. Immune checkpoint inhibitors and TKI combination have increased toxicity and do not have long-term promise. Efforts need to focus on new immunotherapy approaches that could also extend to patients with driver oncogenes. So it might be Virat Kohli, but you have to choose your player as per your view. Thanks.